Hello, I'm Darren Carell, and in this video we'll talk about the use of intravenous patient-controlled analgesia. We'll start with some fundamental concepts. The oral route of administration for opioids is always best, but if the patient requires IV administration for any reason, PCA is most often the better option compared to nurse-administered PRN boluses. Now, if the patient only requires very infrequent IV boluses to supplement other modes of analgesia, for instance an epidural, then it might make sense to just go with PRN IV for this intermittent pain. But if relatively frequent opioid use is needed, then definitely default to using a PCA. Of course, the patient also needs to be alert, oriented, and able to understand and cooperate with proper use of the machine. It's important to remember that PCA is an excellent therapy for the maintenance of already established analgesia. So first, get the patient comfortable with a loading dose or doses, because the incremental dosing will not achieve comfort in a short enough period of time. By the use of a PCA, a placebo effect is imparted, enhancing overall pain control. And most importantly, PCA use inherently helps overcome wide intrapatient variation in opioid requirements by allowing each patient to titrate the amount they receive by using self-administered bolus doses that balance pain relief versus sedation. Along with this is the ability to more accurately determine opioid requirements that can then be used when switching to enteral opioids. The realization that the self-titration via PCA is better than nurse-administered PRN IV boluses was originally described in 1980 and is known as the PCA paradigm. In order to get effective pain control, the plasma concentration of the opioid needs to reach a minimum level for a specific patient in a given circumstance. There is then a range of concentration where the pain control is optimal without leading to sedation or other serious side effects. Because these concentration levels are not absolutes and differ situation to situation, the usually standard one-size-fits-all nursing boluses result in potentially significant time in the subanalgesic zone, and then often pass through the analgesic range and into the sedation zone. Clearly, this is less than optimal. Whereas the more frequent use of smaller doses, self-administered by the patient, results in a much narrower swing in plasma concentrations, thus limiting the time spent in pain and not drifting into the side effect zone. Now, obviously, this is a bit of an oversimplification and describes the ideal scenario with the use of a PCA, but in general, this concept bears out in clinical use. The data published over the years suggests that in comparison to IV PRN, using a PCA results in slightly more opioid use, a higher incidence of pruritus, but importantly, similar rates of other opioid-related side effects like nausea, vomiting, sedation, and importantly, respiratory depression. Pain control is slightly improved with PCA use. It leads to improved patient satisfaction and is certainly preferred by patients. The intrinsic safety comes from the fact that if a patient is getting sedated, they cannot activate the PCA. Because of this, PCA by proxy, meaning someone other than the patient pushing the PCA, must not be permitted, and this must be explained to the patient and any well-meaning visitors. Proper monitoring of patients on PCA is a bit controversial and beyond the scope of this talk, but I do want to emphasize one important point here. At BWH, we use continuous pulse oximetry in every patient on a PCA. Pulse ox is a pretty good monitor of respiratory depression if the patient is on room air. However, it has reduced sensitivity as a monitor of hypoventilation when supplemental oxygen is administered. So I always implore folks to only use oxygen if it's truly necessary. There is not a clearly superior opioid to use in a PCA. Here, I'll talk about the 3 most commonly used agents. The 4th agent we use here at BWH, methadone, is covered in other lectures. One option is fentanyl. Because of its quick onset and short duration, it's a great choice in situations when you are concerned about accumulating effects and/or if the pain generator calls for something fast but brief. The downside is that the patient has to push the button rather frequently if the pain is relatively constant over time. Hydromorphone's pharmacokinetic properties of intermediate onset time and duration, in addition to having no active metabolites, make it almost perfectly designed for PCA use. Also, it is generally more effective in patients who are opioid tolerant. And lastly is morphine. It does have a slightly more delayed onset than the other 2 choices, but in general, it's a fine choice. 2 situations where it's not so fine and relatively contraindicated is in the elderly patient and/or those with renal insufficiency because of the accumulation of the highly active metabolite morphine 6-glucuronide, which can lead to sedation and respiratory depression. The settings that have to be ordered and programmed into the PCA machine are the patient bolus dose, lockout interval, 1-hour dose limit, continuous rate, and rescue dose. The PCA order set consists of 4 templates: high risk, general, opioid tolerant, and palliative care, that are chosen based on the patient's demographics, state of opioid tolerance, as well as the department of the ordering practitioner. The specifics of this last point are that the opioid tolerant and palliative care templates are only available to members of the departments of anesthesiology, perioperative and pain medicine, and adult palliative care. At the top of the order set, you'll see this grid that is meant to aid in choosing the best template for your patient. The first decision point is to determine if the patient is opioid tolerant using the FDA definition here. In this video, we'll go over the next decision point, assuming that the patient is not opioid tolerant, as this population of patients will be discussed in other talks. The next thing to determine is if the patient is at higher than normal risk for sedation or respiratory depression. This list isn't exhaustive, and certainly patients with none of these criteria can still experience these side effects, but this at least gives some guidance. So, if your opioid-naive patient does not have any of these criteria, it's likely best to use what's termed the general template. If instead they do have at least one high-risk criterion, then the recommendation is to start with the aptly named high-risk template. This busy table lists each template and specific opioid, the ordering guardrails, and the default patient bolus doses and lockout intervals, as well as the upper limit of the continuous infusion allowable. Don't worry, we're not going to go through this in complete detail. It exists as a PDF on the prescribing guidelines page of the clinical resources section of the website. As mentioned, we will not discuss opioid tolerant patients in this talk, so we'll focus on the top 2 sections only. We'll start with discussing the patient bolus dose, which is the amount of opioid the patient receives each time they activate the machine. As we discussed earlier, the amount of the demand dose should be small enough so that side effects are minimized, yet large enough to provide effective analgesia. The recommended initial bolus doses in opioid-naive patients are the default values in the order sets. So, for the high-risk patient, it's 0.5 milligrams for morphine, zero point 0.1 milligrams for hydromorphone, and 15 micrograms for fentanyl. And for the, if you will, general risk patient, it's 1.5 milligrams for morphine, 0.2 milligrams for hydromorphone, and 20 micrograms for fentanyl. Given the wide variation in response humans exhibit to the effects of opioids, it shouldn't come as a surprise that the default bolus doses won't be optimal for all patients in all situations. So, if your patient is using the PCA effectively and is still in pain, it is likely an increase in the bolus doses needed. The recommended changes in the opioid naive are to go up in 0.5 to 1 milligram increments for a morphine PCA, 0.1 milligram increments for hydromorphone, and 5 to 10 microgram increments for fentanyl. Back to the hectic table to talk about the lockout interval. This is the amount of time following a successfully delivered demand dose during which the patient cannot self-administer any opioid even if they push the button. It's important to remind patients that the machine does not stockpile the button pushes during the lockout and then administer doses by itself once the lockout period is over. The patient needs to push the button again after the lockout is over to get another dose. As you see, lockout intervals between 6 and 10 minutes are commonly used, and there's actually no data that a specific lockout is better for a particular agent. The next parameter is the 1-hour dose limit. Based on its name, it's, not surprisingly, the maximum amount of opioid that can be administered in an hour. The suggested purpose is to add a level of safety. However, there is no data to support this claim. The other parameters, the demand dose, the lockout interval, and the continuous rate, already define a 1-hour dose limit. If you want the patient to get less in an hour than what is defined by these parameters, then change one or more of them. Because if you enter less than the correctly calculated value, the patient can get a dose every X minutes for part of an hour and then nothing for the remainder of the Y minutes, which really doesn't make a lot of sense. It's fairly straightforward, but just for the sake of it, we'll go over one quick example of how to correctly calculate the 1-hour limit for PCA with the following parameters. Patient bolus dose of 0.4 milligrams, lockout interval of 6 minutes with no continuous rate. You multiply the bolus dose of 0.4 milligrams by the quotient of 60 minutes per hour divided by the 6-minute lockout. Minutes cancel, 60 over 6 is of course 10, so the 1-hour limit is 4 milligrams per hour. The penultimate parameter is the continuous or basal rate. As implied in the name, it's a set amount of opioid delivered every hour without the patient activating the system. They are not commonly used as no benefits have been shown for most patients. They are absolutely not recommended in the opioid naive or high-risk patients, for instance, age greater than 65, concomitant use of other sedatives, those with obstructive sleep apnea or morbidly obese. Which is why, if you recall from our busy table, there is no option for continuous rates to be ordered in the high-risk template. Studies have shown that they do not improve patient satisfaction or pain rating scores and do not decrease the frequency of patient bolus doses. And despite what might seem to have to be the case, nighttime continuous infusions have not been shown to improve sleep or analgesia. And most importantly, they increase overall opioid consumption and are an independent risk factor for respiratory depression. If a continuous rate is being used, be vigilant for side effects, especially respiratory depression, as the pain decreases with time. If a patient has a continuous rate and is not activating the PCA or side effects increase, it's time to decrease or discontinue the basal rate. Remember, the inherent safety of the PCA is the patient self-activation. It's not meant to be solely an opioid infusion. The final parameter is the rescue dose. This is a specific amount of opioid delivered by a healthcare provider, generally in excess of the patient bolus dose, given when the level of analgesia from the PCA is inadequate. For instance, there may be brief periods of increased nociceptive input beyond the ability of the patient bolus dose to be effective, for instance, a dressing change. Or, if the patient forgets to or cannot use the PCA for a period of time, like long period of sleep, they may get behind on their analgesia and require an extra or larger amount of opioid to catch up. In general, the recommendation for the rescue dose is 1 to 2 times the patient bolus dose, and this can be given 2 times every hour. I hope you learned something from this talk. To find a presentation on how and why to query the PCA, please go to the website in the Acute Inpatient Pain Management video series. And as always, thanks for watching.